Good evening, everyone. I'm Bruce Hobson, a family physician and medical director at UBC CPD, and I'm happy to welcome you to this webinar on providing team-based care through primary care networks for child and youth mental health and substance use patients, with an exceptional panel of experts who will answer your questions tonight. And I'd like to begin tonight by acknowledging that the land on which our UBC CPD office is located is the unceded territory of the Coast Salish peoples, which includes the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And personally, I'm speaking to you from the traditional lands of the Quamachin tribe, one of the 7 tribes of the Cowichan First Nations on Vancouver Island. We'd like to thank tonight the Child and Youth Mental Health and Substance Use Community of Practice, which is an initiative of the Shared Care Committee, one of the joint collaborative committees of Doctors of BC, and the BC government for providing funding to support this delivery of this webinar. This is a 90-minute webinar, and I encourage you to participate in the question and answers during the presentation, as this will drive most of what's discussed tonight. We'll be using the slido.com app to be able to receive your questions. So please go to www.slido.com and enter the event code TBC. That's TBC, as in team-based care, which was included in your email invitation to this webinar. Please upvote any questions that are suggested by others to increase the chances of having them answered by our expert panel. And we'll try, but may not be able to get all of the questions tonight in the allotted time for this webinar. So please, the ones that you see that are most relevant, please upvote them. And if you're having any technical difficulties, please note that this webinar will be recorded. You will receive a follow-up email containing the webinar recording, as well as a link to the resources mentioned. And then finally, at the end of this session, please remember to take a few moments to complete the attendance and evaluation forms. In order to obtain study credits, you must complete the online attendance form. You can access these forms via the email link that you received for this session. And I wanted to mention that as the COVID-19 pandemic continues to evolve, UBC CPD wants to especially acknowledge and thank the thousands of UBC faculty members, medical residents, and all the other healthcare professionals and frontline staff who are working in extraordinarily stressful conditions in the healthcare system in order to provide the best care possible. We know that many of you are in the audience tonight, and if this stress is really becoming overwhelming to any of you, please talk to a colleague or call for help through the Physician Health Program at 1-800-663-6729. We cannot thank you enough for your efforts. And this free webinar tonight is being offered with that in mind. That number again is 1-800-663-6729. So let's get started with this session. Our panelists tonight are Dr. Ral Gupta, Shanna Hall, and Deborah Headley, Shirley Z, and our moderator is Dr. Robert Lehman. Unfortunately, one of our panelists, Dr. Wilma Aruda, could not be with us tonight. So please take a moment to review the disclosures for the webinar for the panelists and for those involved with the planning of this webinar. I just wanted to note that there are no conflicts of interest to disclose. So I would like to now pass this over to you, to our moderator for tonight. Dr. Lehman, over to you. Please introduce yourself and take it away.
Good evening. I'm Dr. Rob Lehman. I'm a family physician on the Sunshine Coast, and I'm on the steering committee of the Community of Practice for Child and Youth Mental Health and Substance Use Care in the province. I'm also on our Division of Family Practice Board of Directors on the Sunshine Coast and heading the PCN outreach in our community. And I want to thank you for being here this evening, and thank you, Bruce, for your opening comments. I want to link the concepts of team-based care through PCN, primary care networks, for child and youth mental health substance use care. I had my training in whole person team-based care in family medicine 4 decades ago at the University of Western Ontario in London, Ontario. It was a 4-doctor clinical family medicine teaching practice. Each of those practices had 1 clinical registered nurse per team. And in the whole group of 4 teaching doctors, there was 1 part-time on-site social worker, 1 clinical psychologist, and 1 public health nurse for as I say, the whole group. We had weekly meetings in person for 2 hours for each practice. And then they were also available via phone for advice and for referrals when they were necessary. That was the environment I learned in, but came back to BC, which is where I grew up, and joined a practice at the Gibson's Medical Clinic on the Sunshine Coast, an 8 to 11 member group of physicians, family physicians. We have 1 registered nurse for a whole clinic on site. There are no other immediate community team members, allied health professionals, and through my 40-year career, I've always missed what I knew was a really good way to practice in a team environment. So through primary care networks, there's an opportunity to develop clinical community teams for family physicians, nurse practitioners, and allied health professionals to work together at all of our scopes of practice and sharing our expertise. I know from my own experience and my training that practice satisfaction and efficacy of care is so much greater in a team-based care environment. Our service plan for HCN on the Sunshine Coast is with the government at the moment. So why child and youth mental health substance use care in team-based care environment? I know Shirley is going to speak to this later in the panel, but the prevalence of ACE, as we've been finding out, which is adverse childhood experience, is quite huge, and the downstream effects are also huge in our society. This has led to a lot of suffering and a lot of systemic costs in our healthcare system. The thing is, we can change that. So that's why I began working with the Shared Care Committee for the provincial government and Doctors of BC in the Child and Youth Mental Health Substance Use Community of Practice. On the Sunshine Coast, as I said, our PCN service plan is with the ministry. We'd had a Child and Youth Mental Health Substance Use Working Group leading it into input to that PCN development. We've had the Child and Youth Mental Health Substance Use Local Action Team for 8 years, which is a monthly meeting of family physicians, MCFD, Child and Youth Mental Health, our school district, Shishal Indigenous First Nation here on the Sunshine Coast, Community Services, the RCMP, and Family Smart. We've developed a collaborative kind of environment with information sharing through that local action team. We've developed a doctor in the high school program in concert with Child and Youth Mental Health on the Sunshine Coast. We have done educational panels to our grade 7 elementary school students on information about marijuana and alcohol as they're in that experimental stage leading to grade 8. We're applying for a Foundry site, and we're also planning a collaborative care conference on the Sunshine Coast amongst all of those groups on November the 3rd, just for that relationship building and that networking that's so vital for a team to function. So just want to pass now over to Dr. Shirley Z to have her input to the panel. So thank you.
So my name is Shirley Z. I'm a family doctor in Kamloops since 1979. And as many practicing family doctors attending the conference, you know that you create your own team with your MOA, your local pharmacist, your physiotherapist, that you have relationship with, and you know will provide excellent care for your patient. So I have experience in team-based care in family practice domain. I've also worked with respiratory therapists and diabetic educators, bring them into my office, and nurses as well. Worked with the health authority as division lead, sending the IPCC team of healthcare providers into family physicians' office as team-based care, as the prototype for PCN. So have some experience with that. But my focus today is actually to emphasize the importance of incorporating child and youth mental health substance use care into PCN planning, why it is incredibly important. So, as I mentioned, I started practice in 1979, and it wasn't until November of 2017 that I heard about the ACEs study that was presented by the original researcher, Dr. Vincent Villetti, who came up to our first provincial ACEs summit. And it was like the scales fell from our eyes as to why the adverse childhood experiences and the impact on health is such a tremendous impact that we need to pay attention to. It's touted as the most important public health study that we never heard of. And indeed, I did not hear about it for 30 some years. So what we know about ACEs is there were a number of adverse childhood experiences, but Dr. Anda Villetti collated it into 10 categories, which has been validated for the next 25 years with numerous studies. And the 10 factors are physical, emotional, and sexual abuse, physical and emotional neglect, or household dysfunction, which includes a member having mental illness, the main attachment figure, normally the mother, being treated violently, or the parents having a separation or divorce, or a member of the family being incarcerated or having problems with substance use. What they found is that it was very common. Of the 17,000 study participants, and this was in a California population, that they found 64% have at least one ACE, and that the majority of them have experienced adversity. And this was replicated more recently in the Philadelphia study, which occurred in 2017, where they noted that the systemic issues of marginalized population, the systemic racism, the violence within communities, that there was the additional component of systemic ACEs of up to 73% on the youth and children. And with the what we're seeing out of COVID is that the social isolation and the economic disparity affecting low-income families and female employees have led to more impact of ACEs on children and youth, that we are seeing the emergence of more mental health presentation, both in adult and children and youth, that we're seeing in our offices. So what impact does ACE have on us is that we find that the number of ACEs, irregardless of which one it is, as it increases, the risk of negative health effects increases. So, for example, people with ACE scores of 4 are twice as likely to be smokers, and some more likely to have an alcohol use disorder. An ACE score of 4 increases the risk of COPD by nearly 400% and attempted suicide by 12,000%. So it leads to higher risk taking behaviors, but it also impacts both physical and mental health and substance use issues. So I think that is a compelling reason that if we are able to have an integrated, supportive approach to children, youth, and their families right from the get-go, incorporated into primary care networks where the family doctor has a longitudinal relationship with families, that some of this can be mitigated and the buffering effect for children and youth, which will promote healthy development, will occur more naturally. So that is really, really the important reason why we need to incorporate child and youth mental health and substance use care into PCN planning, as is their physical health. So this slide just outlines the type of behavior that's escalated by increasing ACEs and the physical and mental health issues that are encountered. And you can name any chronic condition, it's represented on this slide. So I'm going to shift my presentation to a really enlightening journey I had to South Central Foundation, which is in Alaska. It is the Native population has taken over back their healthcare from the federal government, form a nonprofit, and they began their whole journey of their healthcare transformation by de-siloing providers, developing well-defined primary care teams, and creating an organization of culture and structure that recognizes the complexity of patient and the meaning in health and wellness. So, and I will proceed in showing their team formation. And why I'd like to highlight is that they, with their team-based care, they decrease ER admissions by 40%, 36% drop in hospital stays. And they have won the 2011 and 2017 Malcolm Bowbridge Award, which is donated by Congress for the highest quality of care provided. And this is what they have created in their team. Their core team is their primary care provider, their nurse, and the primary care provider is a family doctor as well as a pediatrician. I want to qualify that. They have their MOA and a case manager support. But very early on the formation of their teams, they realized that 80% of the presentation to primary care, 80% involved mental health concerns. So they immediately added the behavioral health consultants. And then on the outer circle, they have the psychologists, the psychiatrists, and all the other specialties that are needed. So they are really highly functional, and Dr. Brawl will speak later on about how to form effective teams. So thank you.
Thank you so much, Shirley. So we're going to carry on with the panel. Now we have Shanna Hall from the Ministry of Health. Just a note to the panel members, just to make sure that we allow enough time at the end of the presentation from the panel to have that question and answer period that we're really needing to have tonight. So thank you as we move forward. So Shanna, I'll let you introduce yourself. Thank you.
Good evening, everyone. I'm Shanna Hall. I work in the Ministry of Health in the Primary Care Division as the Primary Care Policy Development Director. So happy to be here. So next slide, please. The primary care strategy, it takes evidence from things like South Central Foundation, and over the last several years in communities across the province, together with you, we have been implementing an integrated system of person-centered, full-service, quality, community-based primary care with the intention to improve access to a longitudinal primary care provider and team. And this works better for people and providers. So the strategy is built around team-based care through a mix of various models that also includes urgent and primary care centers, community health centers, First Nation primary care centers, nurse practitioner primary care clinics, and foundry centers. These are linked together and with other primary and community care services and providers as part of local primary care networks. So the intention of the strategy is that they are to have PCNs, that's the primary care network, locally and collaboratively designed, and it should be based on the health needs of local populations and the service gaps that are identified in each community. So a little bit about primary care networks for you now. These are largely conceptual. They are locally planned, they are geographically based, and they are coordinated systems of primary care. So PCNs create a network that uses team-based care between different clinics and models to deliver comprehensive and seamless health services to the community. As far as a governance structure, a PCN committee really starts with a core membership, which includes the Division of Family Practice, your health authority, First Nations Health Authority, and Indigenous-led and First Nations organizations. And then that does expand as the network develops to include patients, families, caregivers, and additional organizations such as a community health center, for example, in the PCN. The idea is all linked together in a geographic region. So of this, team-based care is intended to be allocated to these primary care networks in order to increase access for people. But this is about adding capacity to primary care and closing what we call the attachment gap, so those without a primary care provider. So where are we now? We have a target in the ministry of 85 primary care networks by 22-23, and realistically, that will be difficult, although we are on our way, and so we're looking at that target to be achieved by 23-24. So there are 59 primary care networks in implementation. Of those, total, we have over 1,100 full-time equivalents hired as part of the primary care strategy. So within those PCNs are strategies such as in the Island Health region, where there's outreach to allow direct referral of children and families from school staff to a family doctor, whether in a school or clinic setting. So that's in Nanaimo. In the Interior Health region, we have strategies that increase team-based care to provide appropriate special services in collaboration with services in the community for child and youth. And then in the Fraser region, we have trauma-informed practice training that's being provided along with mobile services for those seeking mental health and substance use crisis supports. Those are just examples of some of the strategies within the primary care network. And then for team-based care, it's a central model to build towards building diverse, collaborative, and integrated teams of primary care providers. But the idea is it enables and increases capacity and access to primary care. It does provide a more effective response. And usually the team composition is informed by the population data, as well as takes into account the diverse perspectives. So includes consideration of lived experiences when planning for primary care networks using team-based care occurs. So recently there was an announcement, a Health Human Resource Strategy announcement in September 2022. There's 4 pillars, as you can see there, and there are 70 actions in the strategy. And so the idea is that it aims to strengthen healthcare, help alleviate pressures, and lead people to choose a rewarding career. So really, how does team-based care support child, youth, mental health, substance use, and primary care networks? This is the opportunity for us to plan together with your PCN to plan for child, youth, mental health services. In the primary care division, we will connect with MCFD local representation and do our best to support planning for child, youth, mental health services. There's lots of opportunity there. And then just lastly, just kind of going through quick slides. I'm at my time, I believe, but you can see on the slide that of what we have implemented, we have over 170 MHSU related staff. And we work very closely with the Foundry model. And there are 13 of those providing services right now in BC, with 6 more in development. And the idea is that PCM planning supports that. I think that's probably, that's a wrap on the presentation.
Thank you very much, Shanna. So we'll move along now to Deborah Headley from the Ministry of Child and Family Development. So over to you, Deborah. Thank you.
So good evening, everyone. I'm Deborah Headley. I'm an executive director with the Ministry for Children and Family Development, responsible for child and youth mental health provincial services. And I just want to say thank you for your time this evening. And I'm really glad to be here and to be able to share some information with all of you on the services that we provide in the Ministry for Children and Family Development for young people experiencing mental health challenges. And I just want to begin by acknowledging the Musqueam, Squamish, and Tsleil-Waututh nations on whose lands I'm joining from today, and also to acknowledge and honor all urban, Indigenous, Métis, and Inuit peoples who live and work in this beautiful province of ours. I'm just going to refer to one slide today. I have just 5 quick minutes this evening. So I'm going to zip through a bunch of information, but of course, happy to provide more details during the question period if there's interest. And just in these 5 minutes, want to do a couple of things. First, just to introduce you to the child and youth mental health services that are provided through the Ministry for Children and Family Development, or MCFD, you'll hear me say. And then next, just to provide some information on how we do our work, including our work towards our priorities of coordination, collaboration, service integration, and partnerships. And then lastly, just to provide information on how you would find out more information and begin conversations in your communities. So like I said, I'll just speak to one document tonight that you see in front of you, and begin maybe with just a sense of the demand for child and youth mental health services that we experience. So each year, our 88 child and youth mental health teams throughout the province respond on average to about 16,000 referrals, and we provide services to over 25,000 young people in the province. Who we see through our services are young people under the age of 19 and their families. And those are young people who experience moderate to severe mental health challenges that really cause significant symptoms and impairment. Currently, one of the most common mental health challenges that we see through our services is severe anxiety, and that's followed by depression. And what we're seeing now is more complexity than ever before with the young people who are referred to our service. And they're presenting with, on average, about 4 areas of difficulty. So we're seeing young people who may have anxiety, depression, suicidal thoughts, and more. To receive services, young people and families access one of the 92 intake clinics that are available around the province, either through the walk-in clinic days that we offer, or simply by contacting the clinics by phone. And at the end, I'll just share a slide with some information on how you can find information on where those clinics are and how to contact them. And just in terms of the services that we provide across the province, there are 6 core services available to the young people that we see. These are all voluntary services, because they're core, these services can be expected regardless of where you are in the province, regardless of where the service is accessed. So just really quickly, those services are referral and intake services, and that's where a clinician would meet, likely for the first time, with a young person, hear their concerns, conduct an initial assessment, and through that process determine eligibility for the service and also urgency and priority. And at that time, they might provide some links to safe and appropriate and timely supports or services. Following intake, we might provide some initial services while a young person waits for the more comprehensive services that we offer. So that might be something like some brief sessions, group interventions, maybe some resources or referrals. And I just want to note that urgent services, that is another core service that we provide. That's available to young people who present with urgent challenges, such as serious mental health concerns or serious concerns regarding the safety and well-being of those young people or others. So those young people do not wait for services. They're immediately fast-tracked to a mental health clinician for assessment and for safety planning. Of course, we also offer assessment services to young people who are eligible, and that includes a structured and culturally safe assessment. And that assessment is followed by therapy and intervention services. And that's a whole array of trauma-informed and evidence-informed interventions and wise practices, as well as skill-building activities that really engage the family or the caregiver as active partners in treatment. And the last service is just consultation services that we offer to communities, service providers, families, or caregivers. So just in my little bit of time left, I wanted to highlight for you 4 priority areas for MCFD. And all of these are really with a goal to provide responsive and seamless, coordinated and timely access to care. And the first is priority for MCFD is really to develop high quality mental health literacy and prevention and early intervention services. And that's for parents, caregivers, educators, and professional care providers that are there to support the everyday mental health of young people. And it's also a priority for us to provide responsive services that meet the needs of young people and families. So just for example, we provide a choice of having in-person or virtual service. In-person is also available as a choice of having it in office or in a community setting. And the third priority for MCFD is really collaborative and coordinated services. We partner across organizations and with local agencies. So for example, we partner with the 13 boundary centers that you heard Shana mention. We partner in the school districts in over 20 communities in the province, and also with wellness hubs or centers all over the province. And lastly, just partnerships and service integration is a big priority for us. We work in collaboration, partnering and integrating services provincially, regionally, and locally. Our local MCFD leadership works in partnership with regional health authorities and local agencies really to plan for continuity of care of young people and try to prevent some service gaps. And of course, where MCFD is a full partner in the work to implement a pathway to hope alongside the Ministry of Health and the Ministry of Education and the Ministry of Mental Health and Addictions. So I just wanted to flag those 4 priorities because I really think they align well with the values and the vision for the primary care networks, and particularly that work at a local level. That's where I believe the PCN conversation should begin with our local MCFD leadership, and just see where the opportunities lie and the challenges lie that we can work more seamlessly together to better support young people. I know my time is quickly up. I just want to quickly go to the second slide that I have just to flag this for you, and maybe this information we can share out. This is our government page on where you can find the intake clinics across the province if you're looking for service. And thank you for your time this evening.
Thank you, Deborah. Not sure where that slide went, but maybe we could get that information out in the post webinar package. So thank you. Our last panel member that will speak this evening is Raul Gupta. So we'll hand it over to you, Raul. Thank you.
Thank you, Rob. My name is Raul Gupta, and I am joining you from the ancestral and unceded lands of the Sechellt and Squamish nations. And I've had the fortune to work on various small-scale teams in primary care over the last 10 years. And like Rob, would love to see more and more of that happening myself. Most of the teams I've worked on have especially been in the area of mental health, which is more of my focused practice these days. I've also worked for the last 18 years as a coach, and I think that's the main reason I've been invited here tonight. For the last few years, I've been involved as a team coach, working with the Rural Coordination Centre of BC for a program basically meant to support interdisciplinary rural healthcare teams as they come together, recognizing that this work is actually quite difficult to do without some structure. So I'm just going to share my slides here now. What I first wanted to speak to is when we did our literature review we realized, basically what is the impact of being on a team that's functioning well. And so just in case you sometimes question the value, you can look at these different pieces and notice three different main impacts. One is for the patient, and there's clear evidence that we make less errors, that patients actually get more safe care, less care is missed, and there's reduced mortality when teams are functioning well. There's also an impact on providers. We see that many report better job satisfaction, that their teams are actually working in a more improved ways, and that the performance of the team, not surprisingly, improves. I think we can see how these are all interrelated. But then finally, we can actually see how the system itself actually is a benefactor of this as well. And that can be seen by better staff retention, can be seen with greater adaptivity and being able to manage the change that seems to be happening more and more rapidly in our system these days. And not just to be able to respond to change, but even to anticipate developmental needs and therefore act in a more proactive nature. The main thing I wanted to share with you tonight has to do with the 8 elements that we discovered in our literature review. And really this is what has formed the basis of the training that we've been providing. The 8 elements that lead to high functioning teams. I'm just going to say a few words about each of these 8. So first of all, with self-awareness and well-being, when we think about exhaustion and moral injury and even vicarious trauma and the impact that can have on us as individuals, we may not sometimes realize that can change our physiology in ways that actually makes us less social, less able to be a team player. And so taking some time to actually care for ourselves and notice the impact can make a huge difference in how we show up. And then the situational awareness is really important too, for us to be able to sense how other people are doing and recognize that we're in a very complex system that is constantly changing, and the degree to which we can notice these changes makes a big difference. Psychological safety, we've been hearing a lot about, which you can think of as the shared belief that our team is a safe place for us to take interpersonal risks. In other words, that we feel comfortable sharing if we've made a mistake. We feel comfortable sharing our strengths or our concerns, or even voicing things that maybe aren't that popular. Understanding that actually kind of feeds into the fourth one around a supportive, open flow of communication, where we're sharing information freely. There's not this kind of sense of having to pull information from each other, but rather a kind of friendly, generative type of mutual support environment. And then we coined the term empowering team infrastructure really to capture what we were seeing in the evidence around having team agreements, team reinforcing behaviors, team training, all the ways that teams might come together regularly and support each other towards greater accountability, greater camaraderie, and certainly greater sense of participation. And that feeds into the 6th one around a learning culture where essentially we embrace taking chances and maybe even making mistakes, not seeing them as mistakes, but actually opportunities to try something, experiment, and of course measuring the impact of our changes so we can see if we're getting the results that we want. And then the 7th one is what we called a shared commitment to values, roles, and goals. And this is really that sense of having almost a co-created direction that we're going to move towards as a team. Clarity about why we're doing this in the first place and who's going to be doing what. In the literature, they would call these shared mental models. And then the final one, shared leadership. This can be a challenge because, historically, we've been seeing leadership styles that are very hierarchical. And while there are important aspects of that, especially as things are getting more complex, the degree to which we can actually get wisdom from across the team is actually very wise for any team and for any leader. If we can understand that the more we can empower information sharing and decision making across the team, it actually makes it easier on all of us. And if you have been practicing in a place where you've maybe had a bit more authority, that can feel a little bit daunting. I can just say from my own personal experience that there's a lot of relief that comes from that, and as well better results. So this quote from Angel Williams, who's a writer and a Zen priest, I think really captures the essence of this, which is, it's kind of two parts to this. One, that we need to be looking at our own contributions and the places we're coming from, and are we in a state where we can really be available to those around us, and can we come together in ways that actually make things meaningful. The last thing I wanted to share was just a very quick acronym from David Rock that you might find useful. This acronym basically shares with us the 5 domains that we might want to be thinking about, because if these domains are threatened, they might inhibit our physiology towards innovation and collaboration. Whereas if these are honored, it can actually put us into a state where we're much more likely to be creative, much more likely to be pro-social. So S stands for status, the degree to which we feel like we're important to each other. C stands for certainty, our sense that our day is relatively predictable, the degree to which we can actually create some sense of what might be happening in the day or the week, or the scope of our work. The A is around autonomy. Do we have some control over what we're doing, who we're doing it with, how we function, all of those pieces. The R is around relatedness, our sense of safety, again, to speak to each other and to share concerns, and again, keep the silos at bay. And finally, F is for fairness or justice. And again, this is about whether we can keep discrimination or favoritism to a minimum, and if there's a sense of responding to challenges to fairness quickly, so that people actually believe that this is a just culture. So you might want to be just thinking about your own team and where these 5 domains may be playing out, and which ones are already working well, and ones where there might be an opportunity to do something a little bit different. And finally, just to say, we're kind of in some new territory here, and really just inviting us to try some things. Go out there and maybe think about these different elements, and looking for opportunities for yourself as well. And we therefore can fail forward together.
Thank you, Raul. And thank you again to all of the panel members for your presentations. And I hope what our audience is seeing is we're trying to tie together how critical it is that we address child and youth mental health substance use in the province, because it affects so many people, and how we have an opportunity through primary care networks and the networking of that model to really work on developing effective teams in all of our communities. And our communities, there's certainly varying sizes, so your teams are going to be limited by what is available, but there still are others in your communities that are doing this work for children and youth. So I want to thank the panel. So we, through Slido, you've been submitting questions, and I really asked the audience to sign into Slido and look at the questions that are there and vote them up. If there's a question that you really like and you want to have answered, this is your opportunity. If you have your own question, please submit it to Slido. So we're going to start with the first one that's got the most votes at the moment. Is: we are unique in our province that mental health for children and youth is under the purview of MCFD, Child and Youth Mental Health, and healthcare is under Ministry of Health. How does the respective ministries see their role in team-based care under PCN? So normally we're trying to ask one of our panel members to answer a question, but I think this would be valuable for the 2 ministry representatives to have a go. And I know you've mentioned this in your presentations, but I will ask you to maybe elaborate a little bit for the audience on that question.
Sure. Do you want me to go first, Shana?
Sure, go ahead, Deborah.
Yeah.
Thank you.
Yeah, so maybe I'll kick us off. And I think I said a little bit about this in my presentation when I was talking about the priorities of MCFD. And we really do believe that it's best for young people that we're working in partnership, that we're working in collaboration. We're working to provide, the most seamless care that we can for these young people. So it's super important to us. We're involved in lots of initiatives to be able to do that. And PCNs is another one that we're very interested in being a part of for those reasons. And I think that for MCFD, it begins with the conversation, I think, in terms of our role. And I say that mostly conversations, I would suggest at the local level with our local MCFD leadership, because I believe that the relationships at that local level are really important, and the conversations are really important at that level. And I had got a sneak peek at Ro's presentation before and seeing it again today, and I really think that some of what he says is just not some of what you say, all of what you say is really important, but there's a couple of pieces that stick out in my head. And one of them is having those conversations around the challenges and the opportunities and being able to work through that, because I think it's something we all experience. You know, I think when it comes to children and youth and when it comes to mental health, we all experience a significant demand for services and wonder how we can do more. And I think it's working through some of that and understanding how we can work together to provide the best service for the young people that we all support.
Mm-hmm.
Over to you, Shana.
Yeah, thanks, Deborah. And I would just add, that's great. And I would just add that it really is what we're talking about today. It's the relationships, it's the connection as teams, and it also is connection across ministry. So, and cross ministry. Pathway to Hope is a really good example of what they're driving towards with Pathway to Hope is aligned with what Ministry of Health is also mandated to deliver improved access to services for child youth. I think Foundry Centers is another kind of tactical part of the primary care strategy where we are looking to fund PCNs in planning for foundries in their regions, which I think is really like a breakthrough moment. I think it's really fantastic. And so the PCNs is where that opportunity is to bring together various organizations like local representation for MCFD, and then as well some local representation with our Ministry of Health, our primary care division colleagues supporting that. But it really takes these connections and knowing what each are doing and working together the hard way, the relationship building way, to ensure that there's synergies across. I mean, I learned today all that Deborah's doing in her ministry, and it's just so much opportunity to connect, but it is also a challenge. So that's what we hope the primary care strategy does by putting in team-based care in primary care networks, is it fosters that.
Thank you, both of you. We'll move on to the next question. What supports are available to help us organize a child and youth mental health substance use care team in our small rural area? Who would like to try that? Shirley, I'm looking at you, or do you want me to just take a stab at it?
I think you're more rurally located, Rob. I think you're in a better position to answer that question.
Okay, so as I mentioned in my presentation at the beginning, and as you're saying, Deborah, we're working through our local action team, the Child and Youth Mental Health Substance Use Local Action Team, that involves all of the agencies in our community on the Sunshine Coast that are trying to provide child and youth mental health and substance use care. And we've been meeting monthly, even though the collaborative that started this whole process ended in December of 2017, we've continued to meet monthly. And through that local action team, we've established these connections between the Division of Family Practice and Child and Youth Mental Health, MCFD. In fact, I know some of their members are in the audience this evening, and our school district counselors, our Shishal First Nation, our RCMP, our community services outreach workers, and Family Smart. So through those connections, it's all about building the relationships. And we're now at a point where we weren't successful in applying for Foundry in our communities. So we started saying, well, what can we do ourselves without a foundry as far as how being more collaborative in our care? Because even in a small community, it's amazing how you don't know what the other agencies are doing in your community. So we're developing a collaborative care conference on November the 3rd for our local agencies in a relationship building conference. And out of that relationship building, we're going to be doing case scenarios and having groups from each agency grapple with how to manage these clinical problems as they appear. And through that exercise, starting to recognize the scopes of practice of what we can do and can't do in each of those services, but also learning how to communicate with each other better, how to work on issues of confidentiality and privacy, all the roadblocks that can get in the way. How do we refer to each other? How do we get information back? So that's what you can do locally. And even though you may be in a very small community, there's going to be some resources there. And I really encourage you through PCN, the networking, or just through outreach yourself in your communities to find those people that are trying to provide that care. Sorry. So anybody else want to jump in there, or is that okay? Okay. So Shanna, you mentioned that Ministry of Health is supporting the development of an integrated system of care, as specifically relating to child and youth mental health substance use care. What are the steps involved in developing this at a community level?
Yeah, that's a great question, because it's really around how can we leverage the primary care network structure and planning an opportunity with primary care funding coming in right now. So I would, depending on where they are in the region and what their connection is to their local either PCN planning table, if they don't have a primary care network that is already in service planning, which is different than planning, I would connect in with that local PCN group and basically meet with those folks to set, because there is an identified need according to that question. And really that system and those strategies that would be in that primary care network are dependent on that planning group. So it's getting to the table, it's getting their voice to the table, and the mechanism through that is either divisions of family practice, the health authority, the First Nation partners or First Nation health authority, and just identifying those folks. And if they need support in that, then please share my contact information and I can, at the local level, connect them with the right primary care network if needed. But the idea is we need people on the ground to tell us what the best strategy would be for the people in that community. And if it includes child youth services in an integrated way in the primary care setting, or primary care kind of mild to moderate, or linkages to more complex, then we need to hear that from the people that are providing the services locally. Does that answer it? Oh, you're on.
It does for me.
Okay.
So thank you.
Yeah.
If there's a follow-up question from that one, I'll ask the audience member to send us another question. Next question. Okay. Next question is, this webinar is mainly about resources for youth requiring mental health and substance use care. But regarding addictions, I wonder if someone here would be in an advantageous position to discuss research into root causes and what resources are being directed towards preventing youth from being initiated into drug use.
I can take a quick stab at it from my presentation on adverse childhood experiences. We know that that if an individual have increasing number of adverse childhood experiences without the positive buffering, adult buffering, to mitigate the ongoing stress, it causes the individual or that child's brain to be on high alert which can predispose them to more risk-taking behaviors such as substance uses. So we know from the research that individuals with exposures to 4 or more ACEs had a 4-fold to 12-fold increased risk of drug abuse, depression, and suicide attempts. So there's direct correlation that's well validated by research. And in terms of preventative pieces, Dr. Villetti in his original presentation to us was very clear in supporting parents or main figures that the child and youth is attached to in terms of nurturing supportive relationships. That's incredibly important in terms of mitigating the adversity of the negative experiences. And the other piece that part of our substance use working group is exploring and actually advocating for is a program called Preventure that's developed by a McGill professor that's had a lot of evidence that an intervention at the grade 8 level with students that have certain characteristics, giving them a brief intervention has evidence of lowering their entry into any substance use. And it has a herd effect because oftentimes the kids that get into substance use will influence other peer groups to get into it as well. So it has a herd effect. So there are things that are strategies that are happening as well. And we know from our psychologists that work with children that are in the downtown east side in substance use is really delving into the trauma when they're able to being supportive of them and transitioning them out of the substance use when they see an alternative future because they've been so impacted by their trauma that they can't see anything else. And the substance use is a way of relieving that deep hurt they have inside. So there's numerous people, numerous individuals with expertise in this area that is working on that.
Thank you, Shirley. The next 2 questions I have here may also be ones that you might be the one that wants to answer them, Shirley. So I'm going to skip to the next one after those first. Deborah, how has MCFD modified their processes and information sharing to work in a team-based care environment that operates outside of but includes MCFD workers?
Really good question. And I would say, I think in terms of modifying our processes, I would suggest maybe we're still in really early days with the PCNs. I think the conversations are just beginning. So we're not, I don't think we were at a point yet in the work with PCNs of actually modifying processes. But I can say from other experiences that we've had, so for example, the work that we're doing with the Ministry of Mental Health around a pathway to hope, where we're creating integrated teams that include the Ministry of Health and Health Authority staff, Ministry of Education, and some local community service agencies. We are working together. We have developed common policies that we share, common processes, common practices. So just all are aimed at helping us work better together. So any place that we come together and we overlap, we've looked at how we can develop or co-develop policies that would help us work better together. So I imagine with the PCNs, as those conversations start to happen and go further on down the road, I think what I imagine in some of those early communities that are starting, we're going to learn. So as things start to develop and ideas start to happen and things start to shift, that we might be able to take some of those learnings and apply those to other places in the province too, as they start to work. And I'll just speak a little bit to information sharing, because I think it's another question as well. And it's such an interesting question to me. And we bumped up against this also in the work that we're doing with the Ministry of Mental Health and Addictions. And the reason I find it interesting is that we all have processes to share information. So here in MCFD, when we begin our work with a young person or a family, we ensure that we get consent signed to be able to share information. And once we have those consents signed, because we understand that if a family physician is referring a child and family to our services, that they would want to know when they're being seen, what is the outcome of your assessment, what are you recommending. So we do get the consent signed, and then we're able to share that information back with whoever we've been given permission to be able to share with. And that's what we found in the work in the integrated teams that we're creating, is that we tried to think really big, and is there something we can do that just opens the door and we can all share information together? And that's probably way down the road. But we all knew that we had internal processes to be able to do that. And so that's how we're doing it today, while we work towards the grander solution for the future.
Thank you, Deborah. Next question, before I come back to you, Shirley, is I want to draw Raul in. Two questions that are sort of came in around the same time, Raul, but both connected with what you were saying. Raul, how do we ensure that our team has the best chance of becoming, quote, high functioning? You mentioned the 8 elements. Where and how do we start this journey? And then the second one was, again, you might want to just review what you did say. How do you build psychological safety in your team?
Thanks, Rob. Yeah, it's not always easy to know where to start. And, the way those 8 elements were presented, I would say that there kind of is a bit of an order there. So, the word relationship has come up a few times tonight. And I think if we even just thought about really thinking about relationship with self first, and actually just making sure, first of all, the things that Shirley was mentioning around, if we're in a stressed or traumatized state, we actually aren't going to be necessarily in the best place to bring people together or even necessarily be creative. And so doing what we can, first of all, just to make sure that as we come together, we're optimizing that possibility. And then kind of going through relationship with our peers and extending that to relationship with our stakeholders, because no team really exists in isolation. And so starting to understand, okay, what is it that our patients might need? What is it that our funders need? What is it that our other allied healthcare providers might need? And just taking the time, as you mentioned earlier, Rob, about building those relationships. Because this does take time. It's not going to happen overnight, as we've seen with PCN. It's been years in the thinking about, and it's still kind of, in many ways, we're still in the infancy stage of this really being a robust experience across the province, despite all of the great movement that Shanna described. So, sometimes it's taking 6 months, a year, 2 years to really form those teams in a functional way. And sometimes we have to even get clear, like, what's the difference between a group and a team? Because a true team is really, truly interdependent and is accountable to each other and requires each other to function well. And so that's sometimes part of the work, is to kind of get a sense of, okay, who are the key members that we want to really be thinking about? And then just the last part you said around psychological safety, in some ways, to me, that's like the most critical element, and all the other elements will build psychological safety. So the degree to which we can care for ourselves and show up available to other people, that's going to build psychological safety. The degree to which we're aware of other people and what their needs might be, and we're listening versus, strictly giving advice, that's going to build psychological safety. The more we're able to share our truth and create the space for other people to share their own without judging them, and without calling them crazy or getting into the us and them scenario, that's going to build psychological safety. The more we have places to come together and connect, whether it's through huddles or regular meetings or conferences like the one you described, Rob, that's going to build psychological safety because we focus on the relationship and we get to understand each other's priorities, values, needs, limitations. And then the more we involve each other in the decision making, right from the get-go, obviously there's going to be places where some of us can't make those decisions, but wherever we can look for places for building consensus around every step of the process, that's going to build psychological safety. And of course, that takes time. So that's partly where I would say the key part is really around relationship on all those levels, with self, with peers, and then with stakeholders across the system.
Thank you. Shirley, you spoke about ACEs and their impact on health. How aware are other providers in the care team, including police, educators, and ministry workers, about ACEs? How do you see that team having an impact in mitigating the long-term effect of ACEs?
Thank you for that question. I think, as physicians, and this research was done by 2 physicians, I did not hear about this research till some 30 years later after the study. However, I found within my social workers and my MCFD counselors, they were far more aware of ACEs than physicians were when we first heard about it in 2017. And there are certain parts of police officers that are quite aware of this as well. In our local child and youth teams for mental health intervention, they oftentimes have a police officer go out with the mental health workers because they were aware how traumatizing some of these acute situations is, and they needed to partner as a team to de-escalate and improve the situation. So there is awareness amongst others. What we're doing as the ACEs working group is we have convened 2 provincial ACE summits that happened in 2017 and 2018 that invited all the ministries, all the partners, the school principals, the police, and we had the Delta Police Force actually present how they diverted youth to elders when they were caught doing some misdemeanor, and the youth got embraced and cared for and guided by the elders, so they avoided a lot of incarceration. So there is good work, and we have members of our ACEs working group go out and talk to schools and inform the teachers, because ACEs is pervasive. It affects every one of us. So what Raul's words are very, very wise is that we need to understand the impact of our past trauma on the way we behave. It's not what's wrong with us or what's wrong with our patient, it's what's happened to us. Have self-compassion, be self-aware, and then you can work with others within your team to provide that same awareness, to create that holistic, longitudinal care for our patients for the best outcome. And when we fan out that work for child and youth mental health, we definitely need more connections with the school system, more connections with the ministries, and more connections with the ministry. And in fact, we're working with the justice system right now to transform the family justice system in terms of high conflict divorces and the impact negatively on the children and youth. And it is raising awareness amongst the lawyers and the judges and the justice system as well. So there is more than enough work for a couple of lifetimes, and we just can do it, tackle a little bit at a time. Thanks.
Thank you, Shirley. I know I'm just moderating, but that self-awareness that you're referring to is really critical to recognize when we may get triggered by something that our patient does in our presence. And when you understand how you're reacting and how you may be triggered yourself, that takes you to a very different place that allows you to tap into some compassion and response instead of that sense of threat and the judgment that goes along with that. So I'm just really loving what you're saying there. The next question, Shanna, I might see if you could take a stab at this one if you could. How have you worked around the challenge of sharing information about child, youth, and their health issues when you're working with judiciary, educational, and ministry partners, each of whom may have information that is relevant to the whole child or youth health?
Yeah, I am proud that you took a stab at asking me, Rob, but I do not have that information. I'm happy to take it back. That's a lot of players, so I don't have that information. I wish I did. Good question. No. Deborah, I'm not sure if maybe you, because if it starts with a child, maybe you might have some insight.
I think it's a little bit maybe tied into what I had mentioned before, just in terms of how we can open some of the doors to be able to share more information. So certainly within MCFD, we have the consents that we get signed as soon as we see a young person and their family. And I think that's the case for many other organizations as well. The other thing that I forgot to mention the first time around was also just around continuity of care and the legislation around that allows us to be able to share information as well. So I think there are some tools available to us that do allow us to share information, because it's really, really important when we're all sharing the care of a young person that we're able to do that.
Thank you. Again, for Deborah, what tips might you give to physicians to support engagement locally with MCFD?
So I think my one tip, my big tip is just reach out and begin the conversation at the local level. So reach out to the MCFD leadership in your community, the executive director of service. They know I'm on this webinar. I mean, they know we're having this conversation. They know you might give them a call. So I think my number one piece of advice is to do that. And then I would refer you to all of the advice that Raul has presented tonight, which I think is really great to go into the conversation around how we can create safety, how we can work with one another, how we can make those conversations work in the best interest of the young people. So, yeah.
Thank you. So I'm going to bounce it back to the two of you again, to Deborah and Shanna. Are the Ministry of Health and MCFD looking at a way to communicate information about a youth who is transitioning to adulthood with mental health issues, that is EMRs that can connect with each other and or with the primary care provider's EMR?
Maybe you want me to just jump in and see what I can think of. I would suggest that formally we're not doing that right now. But I also wonder about the work of the Ministry of Mental Health and Addictions, who we don't have on the call today, because a pathway to hope is all about how we can work better together, how we can provide more seamless service, work in an integrated way. And we're just beginning that work as well. And I think even through the work that we've been doing around creating integrated teams, we've created kind of like an interim system that can help us to be able to share some information across ministries. And that's just the start of it. Maybe down the road, there could be sort of a more formal approach to how we could do that together.
And I would add that, in the Ministry of Health and in primary care in particular, there is a digital enablement strategy that we are just looking at, one digital door for a lot of folks. The shared EMR is goals, if I may, that we've all had for much, like a long time. But when it comes to our work with Ministry of Mental Health and Addictions and kind of looking at that's 17, 18, 19-year-old at that sort of point in care where they could get lost, we're looking at what a shared EMR platform would look like, what e-mental health services would look like. So we're partnering with Ministry of Mental Health and Addictions around that bridge, and that that there are truly seamless transitions in care for people. So that is definitely part of what the work that we're undertaking, but probably a ways off because it has so many dependencies related to it. But it's certainly part of several strategies, I would say. It's not just words on a page, it's people working towards it.
Yes, at a local community level, our aim is for that more wraparound model and being able to work together in a team. So it's really encouraging to hear the two of you talking about recognizing how important that is, that the child serving ministries also are engaging with each other for this benefit of our young people. So, Deborah, can you please clarify MCFD's role in emergency situations?
Mute first. Be helpful. So I think I maybe spoke a little bit to this in my presentation, and just to reiterate that there really is a priority of MCFD to provide the most responsive service that we possibly can. But I will say, I think it references too that all of us in this field really experience significant demand for services that very often exceeds our capacity to provide the level of responsiveness that we envision, that we want to. So what we do in MCFD is we use an evidence-based system to prioritize the young people that we see. And that's really to ensure that we see those that are in the most urgent need of services first. So that's the urgent services that I mentioned through my presentation for those young people that present with urgent challenges, that have serious mental health challenges or really serious concerns for safety and well-being. And those young people, they do not wait for service. They're immediately fast-tracked to a mental health clinician for assessment and for safety planning. And how you would access that is just through contacting the CYMH office and ask to speak to the intake worker and let them know that you have a patient with an urgent mental health need. And it'll be through that if the young person is deemed high risk, we would do our best to connect with them. We do our best to complete a risk assessment as quickly as we can, and to work with everyone that's involved in the development of that safety plan while we're fast tracking them for treatment services and trying to arrange to meet with them as soon as possible. So that as soon as possible, there are some limitations to that. It is during our working hours. We're not a 24/7 service. We're not set up to be a crisis response service. So it's usually later, maybe later that same day, if that's possible, or maybe the following business day that we might be able to see them. And I also just want to note that sometimes those safety plans that we can create are not enough to keep a really high risk youth safe when at home or in the community. So we also recognize that it's really important to get the right service to the young person as quickly as possible. So that's why we might also facilitate getting access to the best service providers that can keep that person safe and stabilize them in an emergency situation. And so that may be that we're advising to call 911 or to take the child or youth to the nearest hospital or emergency department. And that's really when there are no other appropriate community resources that are able to respond and support that young person. So I think it's kind of a yes and no. It depends on the situation, but we do our very best to be able to respond as quickly as we can in those situations.
Thank you. And PCN is about community networks, but we do have to make sure that community network also transitions to and from our acute care services in our communities as well. So it's really vital that we don't make more silos, that we just really right from the start learn to work together and to make it as seamless a system as possible. So thank you. Raul, again, I know you referred to this, but what defines a team and how is it different from a group?
Yeah. Well, I think the key part around teams is that there is a sense of a shared mission. And not only that there's a shared mission, but that there's an interdependence to each other and an accountability to each other. And so that creates a bit of a problem with our current way of handling healthcare because, people can work in their silos as they currently exist, and there isn't immediately a sense of interdependence, and there may not even be a shared mission that's actually been well defined. And I think that's why some of this initial work is so important, to go back to the table to really think about who are the stakeholders, who actually are the people that I want to kind of cultivate a team approach with. And therefore that means coming up with a co-created vision, a shared idea of what we want to create together. And how are we going to hold each other accountable? So that requires both, like there's this marriage of creating the safety and relationality with each other and some accountability to each other that is not from like a judgmental, critical place, but actually because we're all deeply inspired by a shared mission. And that's very different than a group where, you could exist. Yes, you might want to support each other, but you could get by without each other to a certain degree and just kind of live your smaller vision, so to speak, but then probably certainly not serve the patients ultimately as well as we might.
Yes, and I totally hear what you're saying. And for my career, I've worked in a group, a lovely group, but the opportunity here to have a team with that interdependence and that recognition of all the team members' expertise and scopes of practice and capabilities is huge. And how you do that in a system where we have been, as family physicians, functioning pretty independently and trying to do everything for everybody, and suddenly have a system where we recognize the merits and the value of a team, and how do we promote that team to actually occur, say if we get it, all the people we wished for in our PCN requests. So that to me is going to be the next challenge, is making allied health professionals that come into our PCNs engage with primary care providers in the communities to function as a team, as opposed to just another referral service and a group. So I wish I had the answer to that, but it's a good challenge. Shirley. You're on mute, Shirley.
I wanted to add a little bit more to what you and Raul spoke about, is in the South Central Foundation system of care, they're very intentional in terms of cultivating, even at the early age, of people that want to work in that team-based care environment, is aligning their vision and mission really intentionally. And then they do personality groupings of all the, if they have a team, they find out, how they function. And we all function very differently. Some people are more like they like to take control. They like to be active. Other people are more contemplative. So there's different personality styles. They even go to the point of making sure that the teams are balanced in terms of their personality approach, to complement each other. So there's really intentionality incorporating some of the principles of relationship building that Raul spoke about self-awareness, and that accountability piece. So it doesn't happen by just throwing people together. It just does not work well that way.
Thank you. And we are running down to 5 minutes left in the webinar. And again, I want to thank the audience for being here and for the great questions that were asked. And really want to thank all of the panel members for all of your superb input to this topic as we try to tie together the opportunity we have for team-based care through PCN, and particularly to address the needs of our children and youth and their families that are suffering with mental health and substance use problems. So as a final 1 to 2 sentence pearl from each panel member, I want you to think about one pearl you want to leave the audience with in 1 or 2 sentences. So we have about 3 minutes for this. Just to leave the audience with something to take away, although I think there's a lot to take away already, but who would like to start with that?
Okay. All right, tootled about with this a little bit. Collaborative minded and interdisciplinary focused professionals working together who are valued, who value building teamwork, are given tools to do so in order to deliver effective and optimal primary care. This was before I heard Raul's and Shirley's and Rob's excellent points, however, but there's my 30 seconds.
Thank you. Another volunteer?
Well, I can go next. So just want to say thanks for the opportunity to share all the information on our services to start. And I think I really hope that the discussion opens up great opportunity for us to work more seamlessly together and build partnerships to support the young people that we work with together that are in need of mental health services in the province. And just really encourage people to have the local conversations, understand the challenges and opportunities, and work together. And I encourage you to reach out to your local MCFD leadership to start those conversations.
Thank you, Deborah. Another volunteer, Shirley?
I'll volunteer. I think it's an exciting opportunity at this juncture for PCN, and knowing the impact of ACEs on overall health, that is incredibly important when we have respective ministries, Ministry of Health, MCFD, and the Ministry of Mental Health and Addictions with their Pathway to Hope. Exciting opportunity for us to embark on this work. I talk about the South Central Foundation and their really outstanding team-based primary health care. But they said it took us a decade to get here. Rome wasn't built in a day. So we're starting in those baby steps like Raul is talking about, but we're embarking on an exciting journey, and I'm crossing my fingers that we will be able to get there and do the work that we need to provide care for our children, youth, families, and all the patients that we serve.
Thank you. Do you want to take a stab at it, Raul?
Sure. Just maybe following with what Shirley said. One of my favorite quotes these days is from a fellow Bayo Okomalafe, who says, "The times are urgent. Let us slow down." And I love that because I really think it speaks to slowing down, to be intentional, to focus on relationships, to really understand what we're finding ourselves in, so that whatever choices we make will just be based in compassion and grace and some wisdom.
Thank you. And I'm just going to throw in a couple of lines. I wrote this before the webinar, but it still resonates for me we need to decrease the suffering while increasing provider satisfaction and efficacy of our care and patient satisfaction and outcomes, and decrease the system costs through a whole person team-based care approach to youth mental health and substance use and community care in general. So thank you again, everyone, and we'll hand it back to you, Bruce. Thank you.
Thank you, Rob. And I'm sure everyone would love to continue hearing more from this very knowledgeable panel. we've reached 90 minutes and it's time to wrap up the webinar. I'd really like to express my sincere gratitude to this great panel, Drs. Raul Gupta, Shirley Z, Shanna Hall, Deborah Headley, and our moderator, Dr. Rob Lehman. And thank you very much for taking the time from your, I'm sure, very busy lives and heavy responsibilities to present and answer the audience's questions tonight. And I'm sure everybody really appreciated it. And by the way, I wanted to also acknowledge our very hardworking UBC CPD staff, without whom the delivery of these webinars would not be possible. Bob Blumen, Brenna Lynn, Stephanie Amio, Steph Din, Haresh Gidwani, and Manat Sidhu. Thank you, all of you. And this, for the audience, this webinar is accredited for up to 1.5 Main Pro Plus or Section 1 credits. So please remember, take a few moments right now to complete your attendance and evaluation forms that were emailed to you so that you can obtain study credits and provide your feedback on tonight's webinar. And you will be receiving a follow-up email containing tonight's webinar recording, as well as a link to any of the resources that were mentioned tonight. So thank you again, everyone, and have a very good night. Take care.